3% more progression in X-ray change 2 years down the line, and a similar result with the second point. The shorter duration at the start of disease treatment produced a much better response within a year. The European League Against Rheumatism guidelines suggest that patients should be referred within 6 weeks of onset of symptoms and start treatment within 3 months. But a survey, and this won't surprise you, in 2004 in the UK showed that only 50% of patients actually do reach a rheumatologist within that time. So, there's not a lot of hope in terms of introducing treatment early. And diagnosis in itself is difficult. So early treatment, if that's the goal, means early diagnosis. So I'm just going to say a little bit about how we diagnose rheumatoid earlier than otherwise has been the case. Well, this is obvious. For most of us, when patients come through the door with a dramatic, crippling, symmetrical polyarthritis with high inflammatory markers, a positive rheumatoid factor, the diagnosis presents no difficulty. An aggressive intervention is clearly indicated both the patient and the doctor. But it's those patients that present with insidious onset, no dramatic synovitis. Dry synovitis is a recognised entity, a lot of pain, quite a lot of restriction of mobility, but actually not so much to see in the way of swelling, and perhaps not so much in tenderness, where the investigations may be normal or only slightly elevated in terms of inflammatory markers, perhaps a negative rheumatoid factor, negative anti-CCP antibody. Then the diagnosis, it's largely a clinical skill, based very much on the history. So it's not an easy thing. Now, we do have some recent tools which have been made available which help us, and I'll talk a little bit about these. Anti-cyclic citrullonated peptide antibodies, for example, and some improvements in imaging. Now, these anti-CCP antibodies, raised antibodies can identify patients with rheumatoid before more classical features appear, such as the positivity of rheumatoid factor, or perhaps the full house of clinical signs and symptoms, or X-ray change. In fact, it's known that these antibodies exist sometimes positive in patients for several years before disease evolves. They're advantageous because they're more specific, the rheumatoid factor, positive in 80 to 85% of patients with rheumatoid, which you remember the rheumatoid factor is positive in about 75% of patients who eventually turn out to have rheumatoid. And just as importantly, perhaps more so, they're more specific. So if you find a positive anti-CCP antibody, your patient is almost certainly going to have rheumatoid. Whereas you'll remember that rheumatoid factor is positive in other disorders, such as chronic infection, chronic autoimmune liver disease, other rheumatoid conditions such as Sjögren's, and connective tissue disorders, systemic lupus. I've mentioned the fact that anti-CCP antibodies are also found in patients with psoriatic arthritis and Sjögren's. Actually, it's a very small percentage. They also carry some prognostic value. If they're present at presentation, particularly at high levels, they can incur a worse prognosis and increased risk of erosive disease. This is also, of course, true for rheumatoid factor. And you'll see a good example of fairly advanced erosive change in that foot there at the metatarsophalangeal joints, and also in the hands with the deformity on ulnar drift. So anti-CCP antibodies helping in early diagnosis and has some prognostic value. What about imaging? I'm not going to say a lot about MRI, but you'll know where it's accessible to that this can make quite a lot of difference. You don't often actually need to use it in clinical practice, but occasionally it's useful in terms of picking up erosions if you're not quite sure what's going on. Ultrasound has more of a place. It's cheaper and becoming very much more accessible in the UK. As I said earlier, I work in Basingstoke, which is the region is the Wessex, and very few rheumatology units in the Wessex area are not using ultrasound, portable ultrasound, to diagnose rheumatoid at a relatively early stage, quite apart from monitoring the disease process. You can pick up early erosions in a manner that one would not be able to using normal X-rays. And you can see here an example of erosive change seen on MRI. Just see an erosion here, and here you can see the same erosion there on MRI, and you're picking up the same erosion on ultrasound there. So with the experienced eye, and it does take experience ultrasound, These things are not too difficult to pick up.